When we say bloodstream infections, what do we mean? The first thing is infections means there must be a positive pathogen. That pathogen must be present in the blood. Blood, what is the blood present? It is present in the vessels. So anywhere in the blood or the vessels, if the pathogen is present, that should be the first criteria. The second would be what are the consequences of the presence of an organism. So normally we do not expect any kind of microorganism to be present in the blood or vessels. So if it is present, there would be consequences. Consequences can be as severe as can cause DIC and even death. What is DIC? Any idea? Dysentery. Now, depending on the type of the organism that is present, if the organism is a bacteria, we call it as Bacteremia. If it is a fungus, we call it Fungemia. If it's a virus, we call it as Viremia. Similarly, if it's a parasite, we call it as Parasitemia. And sometimes the organism may not be present, but the toxins present in organisms may be seen in the bloodstream. That we call it as toxin. Any examples that you can think of? Diphtheria is a very good causes toxin. Anything else? Okay, give an example of a parasitemia. Any parasite that you know? Malaria, filaria. Okay. Now today we'll look predominantly at the bacteria because that is the most common cause. Now bacteria can be either transient bacteria, continuous bacteria, or intermittent bacteria. Now what do you understand by transient bacteria? Transient, what does the word transient means? Transient মানে কি? Or a very short span of time. So many times we do many kind of activities in which microorganisms can translocate from a particular site So microorganisms can translocate from a particular site into the bloodstream. Most commonly, this is seen with mucous membrane. So normally, organisms may be present on mucous membrane and they do not gain entry into the bloodstream. But many factors, for example, when we brush our teeth, we are actually manipulating the gums. Microorganisms are present in the oral cavity. When brushing, these microorganisms may enter into the bloodstream. What will happen? They will be very commonly killed if the patient is not immune compromised. That is called as transient bacteria. Similar transient bacteria can also be seen in patients hospitalized. For example, if a patient is hospitalized and is not taking food per oral, so the gut microorganisms may translocate from the mucous membrane into the bloodstream. It could be transient, normal, but if the conditions get prolonged, it may become intermittent or continuous. Then when we say continuous, what do we mean? That means there is a focus anywhere in the body where the microorganisms are present, and from that area it is continuously gaining into the bloodstream. Continuously. That is called as continuous bacteria. And last part is intermittent. Suppose there is a deep-seated abscess in the muscles. The organisms are present in the abscess, but these organisms are not spreading continuously into the bloodstream. Sometimes, let us suppose when the number of bacteria increases, it spills into the bloodstream and it causes bacteria. So what we will get? We will get intermittent bacteria. Now why I am telling you all this? Because we have to look how the bacteria gains into the bloodstream, and it also will determine how we diagnose the bacteria from the laboratory point of view. Okay. Now next part is we have to understand the two terminology called primary bacteremia and secondary bacteremia. Primary means, and primary और secondary बोलते की बोल? Secondary. Primary means there are some infections in which the organisms cause the pathogenesis revolves around spreading through blood. That is called as primary bacteria. Secondary means the pathogenesis is elsewhere, but it spills into the blood. That is called as secondary bacteria. Now, if I give you an example, a patient has come with a injury to the leg, and now he has developed an abscess over the leg. And if he develops bacteremia, what will be that? That will be secondary bacteria. But if a patient gets infected with, say, is having symptoms of enteric fever, that means Salmonella typhi is causing primary bacteria. The pathogenesis revolves in the infection of the bloodstream. Another classification would be intravascular and extravascular bacteria. If you look at the same pathogen from the point of view of pathogenesis, the causes or the organisms which cause primary bacteremia, main focus of infection is bloodstream. That means the infective process is going in the vessels itself. That is also called as intravascular bacteria. And if the process of pathogenesis develops elsewhere, we call it as extravascular bacteria. Now, this is a short list how they gain entry into the bloodstream. It could be through urinary tract, intestine, respiratory tract, or reticular endothelial system, or even through wounds like surgical wound or traumatic wound. These are the gross sites from which a bacteria can enter into the bloodstream. Now, there are some things that you should know about who are more predisposed. If you look at all the options that are seen over here, immune suppression, obviously, the innate immunity protects us. And if the innate wing of the immune system is disrupted by medication or a disease or any cause, that means those people will be more prone for infections. Similarly, with the use of broad spectrum antimicrobial agents. Why? Antibiotics spawn. Actually, what happens is that when we are using broad spectrum antibiotics, we are changing the flora of the set. Let us suppose a normal human being will have a particular type of bacteria in the gut. Now, if I give broad spectrum antibiotics, what will happen? The commensal bacteria will die, and some bacteria will remain. Which bacteria will remain? Those which are resistant to the antibiotics. And if one of those bacteria have virulence factors, it can easily translocate from the mucous membrane into the bloodstream, which was earlier not easily possible because the commensal bacteria will not allow it to go. So these kind of scenarios can be especially seen in hospital settings like invasive process, surgery, use of antibiotics and immune suppression. These patients are more predisposed for bacteria. Now, having understood this, now again let us look at the kind of infections that can be seen in case of Vessels. What are the vessels we have in our body? কি vessels থাকে? Okay. Artery and then veins and okay. Anything else? Lymphatics is part of the reticular nucleus system. And the biggest vessel, heart. Now heart will have 3 parts. What are the 3 parts? Outside is pericardium, then myocardium and endocardium. If an artery is infected, we call it an arteritis. If a vein is infected, we call it as phlebitis. If pericardium is infected, we call it as pericarditis, myocarditis, and if the endocardium is infected, we call it as endocarditis. How many of you have a intravascular line anytime in your life? No one. Have you seen patients with IV line? So IV line can be peripheral line or could be a central line. Peripheral means the veins on the limbs, and central line means which are directly gaining access into the central veins. Now phlebitis means inflammation of the veins. It could be infective, it could be non-infective. Now among these, we are very much concerned about these two. For pericarditis to happen in isolation, that means the infection or inflammation should proceed from outside, then only we get pericarditis. However, for endocarditis and myocarditis, the inflammation is from inside. Now, endocardium comes in contact with the blood. So, endocarditis is probably the most common feature if the blood gets infected. Now, when we say itis, that means it's inflammation, endocarditis. I've already told you it could be infective, it could be non-infective. Today, we'll discuss about the infective forms of endocarditis. Now, endocarditis is defined as, when we say endocarditis, I'm talking about infective endocarditis. So, infective means there is a microbial infection where of the endocardial surface, and it may infect valves, which could be natural or prosthetic. Prosthetic means people who have undergone valvular repair or prosthesis, maybe because of any cause. It could be a valvular defect, congenital defect, etc., etc. And finally, a very important part is this one. It is called as vegetation. Now, when we say vegetation, we must understand what is a vegetation. Vegetation means it's a outgrowth, like a tree. How can this growth occur in the endocardium? This is because of a collection of, obviously, the microorganisms which is causing it, along with other cellular debris. What are these cellular debris? It includes platelets, fibrin, and inflammatory cells. Now, before going where these vegetations are seen, first of all, try to understand why these vegetations do occur. Suppose in a case, in a patient, normal patient with no defect, what do you think is the maximum force that is exerted on the endocardium? It's the valves, which controls the blood pressure. So the maximum force is rendered to them. Now this pressure is sometimes sufficient to cause small damage in the valves itself. These areas are then slowly what will happen? The microorganisms get lodged in these areas. And what the body will try? It will try to contain the infection by recruiting inflammatory cells, depositing fibrin and platelets that are present in the blood. When they all agglomerate at a certain place, we call it as a vegetation. Now that you have understood why this vegetation occurs, so where can we see the vegetations more commonly? We can see them more commonly at the heart valves, the chordae tendineae. What are chordae tendineae? The tendons of the valves. Then endocardium, then endothelium, and finally septal cardiac abnormalities. Suppose the patient may have a small VSD or an ASD. So the edges of the septal defect, they also undergo microtrauma repeatedly. So these are the areas we need to look for vegetations. How we look for? Obviously by echocardiography. So not only we must know what we are looking for, we also have to know where to look for. Now these are the risk factors. You are already acquainted with rheumatic heart disease. I have already told you about rheumatic heart disease. Then any kind of degenerative arterial or mitral valve disease or intravenous drug use. Now why intravenous drug use is important? Because whenever we are injecting something, there is a chance we are injecting a microorganism directly into the vein. That means we are allowing the access of microorganisms into the bloodstream. Hence, intravenous drug users are more prone for endocarditis. Obviously, they do not take sterilization things more important, very. Then, poor dental hygiene. Same concept. For a normal person, when he is brushing the teeth, we will observe transient bacteria. If a person is not maintaining oral hygiene, what will happen? Various types of pathogenic organisms will grow in the mouth, and then any kind of dental caries or any dental manipulation will lead to translocation of the organisms from mouth into the bloodstream. And similarly, other diseases like diabetes mellitus, hemodialysis, etc., these patients are more prone for infective endocarditis. Now, clinically, how will we suspect? Now, it's infective and it's inflammatory. The first sign of inflammation is obviously fever. So, patient will complain of fever. Then, because the valves are involved, we can see murmurs, splenomegaly. Why? Because see, in response to the infective process, spleen clears the cells which are damaged into the bloodstream. The spleen will undergo hyperactivity. It may also lead to splenomegaly. Other things can be seen, new or changing back and joint pains, and these are the peripheral manifestations. Now, when you look at the peripheral manifestations, first is sphincter hemorrhages. Because these vegetations may dislodge from the heart and it may reach anywhere in the body. It may form Osler's node, Janeway nodes. These are the cutaneous manifestations. Or it may also lodge into the pulmonary region, in the pulmonary blood circulation, leading to cough, dyspnea, and chest pain. And finally, if the vegetations gain access into the cerebral circulation, it may also lead to strokes, or due to vegetations. Now let us look at the microorganisms. Look at the microorganisms. Before you look at the microorganisms, you must understand two concepts. The first concept is, one is called as culture positive, another is called as culture negative. When we say culture positive or culture negative is how these things have developed. Keep in mind the IVDs, that is the in vitro diagnostics, have improved by leaps and bounds over the last 100 years. Earlier, the concept was very simple. If the microorganism or bacteria is present in the blood, if we take the blood and do the culture, we will get the organisms. Later on, it was seen there were some bacteria which were causing the endocarditis, but we were not able to retrieve them in the laboratory by culture methods. Those were defined as the causes of culture negative endocarditis. Similarly, culture positive means those organisms which can be isolated easily. So, which are the organisms? The common organisms which include streptococcus. So, these are the streptococcus. If you go and read sanguinus, mitis, these are all present in the oral cavity. Again, if you look at staphylococcus, aureus and coagulus negative staphylococcus, all are associated with the skin and nerve. Finally, you can see enterococcus, gram-negative bacilli like E. coli, Pseudomonas. These all originate from the patient's own body. These are not from external environment. Next comes culture negative endocarditis. When we say culture negative, that means by conventional culture methods. So some of the organisms were not earlier easily diagnosed by the routine culture methods. Those include, very importantly, the Hassett group of organisms, Coxiella veneti, Chlamydia, Bartonella, and the first point, Abatrophia graniculata. These are called as nutritionally variant streptococcus. That means they have a specific nutritional requirement. If you do not provide that, it will not grow. Okay. So these are the two broad classifications. Now, when we have already said the culture is important, so what would the first step of diagnosis? We have to do culture. The organism is present in the vessels, so we need to take the sample from the vessel, that is the blood. Now the question comes, when to take the sample? I think you already know how to take a blood sample, but the question comes, when to take and how many? That is very important, because you have to remember, even though the organism is present within the bloodstream, the organism is present within the vegetations. That means there is not continuous seeding. It will be intermittent bacteria. So you need to take multiple sets of blood culture. Then only you can get the results as positive. Otherwise, you will get a false negative results. So what are the minimum requirement? At least 3 sets. One set means 2 blood culture bottles, one for aerobic and for anaerobic. So at least 3 sets of blood culture should be taken, and they should be drawn from different sites. Why different sites? Why different sites? Skins. One bottle might get contaminated with the skin commensals. But if you get culture positive in, say, 2 sets of blood culture, it is highly unlikely that this is a skin commensal, because you have taken from different sets. So always remember, if you are trying to diagnose infective endocarditis, you need to take 3 sets of blood culture, or it should be drawn at least 1 hour apart and from different sets. মনে থাকবে কি বললাম? যদি ইনফেক্টিভ এন্ডোকার্ডিটিস সাসপেক্ট করো, at least 3টে সেট অফ ব্লাড কালচারে ব্লাড নিতে হবে, all from different sites and at least 1 hour apart. Okay. Other than that, we have to do another series of tests, among which would include complete blood count, BNP, antibodies, and other, including ECG and echocardiography. For diagnosis, we have to, there is a criteria, it is called as modified Duke's criteria. There are some major criteria and minor criteria. Let us look at the major criteria. First is a typical organism found in 2 separate blood culture sets. Typical means organisms associated with culture positive infective endocarditis. Yes. A known pathogen, if it is recovered in 2 sets of blood culture, that means it's a major criteria. Second comes is persistently positive blood culture. What do you mean by persistently positive blood culture? I will come to that point. I will also teach you about fever of unknown origin. Sometimes what happens is that we get some patients who have fever. And why it is called of unknown origin? Because there are no additional guidance or indications for a pathogen. In those case scenarios, what we do is we send repeated blood culture samples, not in sets like infective. Infective endocarditis, if we suspect, then we send 3 sets. But sometimes what happens is we are evaluating a patient in whom a blood culture was sent. Then we think the patient is still febrile. We send a repeat blood sample, and both the reports come positive with a organism which is known to cause infective endocarditis. That is the time when we say it as persistently positive blood culture. Have you understood? Next, again, we also have to consider about the organisms which do not grow in culture, like Coxiella bonnetii. Coxiella পড়ানো হয়েছে? পড়নি? Bacteriology হয়ে গেছে? So it is very difficult to grow them in culture. They almost behave like viruses, and we generally have to grow them in cell line cultures. So when you take a blood culture, it is highly unlikely that you are going to get it. But what happens is that we get culture positivity. So in those case scenarios, we get antibodies. So a rising titer of antibodies against those pathogens will also indicate that this could be an possible infective endocarditis. Along with that, we have some minor criteria. Among the minor criteria, one also major important criteria, if we can visualize vegetations on echocardiography. You are evaluating for infective endocarditis, you send the patient for echocardiography, and on echocardiography you can see vegetation. It is a direct indication. Okay. Now also keep in mind this Duke's criteria. It has been modified slightly by the 2023 recommendations. As far as you people are concerned, I am not going to discuss about the changes in recommendation as of today. Just try to understand why this criteria was made. Okay. You will eventually have to learn about these criteria, the recommendations, what are the possible causes of endocarditis, possible, probable, these criteria. I am not. So, by the Duke's criteria, again, like acute rheumatic fever, we have major criteria, minor criteria, and when these criteria are fulfilled, we can call it that this is an infective endocarditis. Another entity is called as non-thrombotic endocarditis. There is thrombotic endocarditis. Now, what is thrombotic endocarditis? It is not infective. Over here, what happens is, especially it is seen in which any kind of intracardiac instrumentation is done. There is small trauma into the endocardium, and over the trauma there is a growth which is mainly composed of platelets and fibrils, but no microorganisms. Okay. Infective endocarditis can also be divided into two parts. One is called as acute endocarditis, another is called as subacute bacterial endocarditis. Now, as the name suggests, acute means the presentation is very rapid, and subacute means the presentation is very insidious. Acute endocarditis can be very commonly seen with a known pathogen like Staphylococcus aureus. It is a very virulent pathogen, hence the manifestations will be severe and very acute. Whereas subacute bacterial endocarditis is commonly seen with streptococcal species. These are commonly the commensal species, and the infective process is very slow. Now, why this is important? Because many a times these patients will present only with fever, long-standing fever, and this was earlier called as pyrexia of unknown origin, or PUO. Initial definition that was given by Pathogenic a long time ago, he defined that pyrexia of unknown origin can be given to a patient in whom at least 3 weeks of investigation done, yet we cannot give a diagnosis. But as of today, that definition no longer stands. Why? Because of the improved diagnostics, we can investigate a lot more in one day. So, as far as today's viewpoint is concerned, fever of unknown origin means a patient presenting with fever in whom the routine tests that are done, they do not give a conclusive diagnosis. If that is the situation, we call it as fever of unknown origin. Again, fever of unknown origin could be infective, could be non-infective. There are many non-infective scenarios in which the patient may present with fever. There are malignancies, I think we have already read in pathology, lymphomas, leukemias, they present with fever. So it could also be a non-infective, or it could also present like an infective. It could be tuberculosis, it could be histoplasmosis, etc. and etc. Now, fever of unknown origin have also been classified into many types. One type is, any idea how we can classify? No. Based on the patient profile. It could be a fever of unknown origin in HIV patients, in case of immune compromised patients, in case of nosocomial FUO. Nosocomial means fever that is present in patients who have been admitted or is admitted in the hospital. Those are called as the nosocomial FUO. Now, why this FUO is important? Can important? ফিভার অফ আননোন অরিজিনটা ইম্পর্টেন্ট কেন আমি সেটাই জিজ্ঞেস করছি। ট্রিটমেন্ট তো পরে করবে, আগে তো তোমাকে আইডেন্টিফাই করতে হবে না কজ অফ দ্য ডিজিজ, কখন সাসপেক্ট করবে সেগুলো তো ইম্পর্টেন্ট। যেমন ইনফেক্টিভ এন্ডোকার্ডাইটিস ইজ sometimes may present as a cause of FUO. বুঝতে পেরেছি FUOটা কি না বুঝতে পারবো না, ইম্পর্টেন্সটা কোথায়? পেশেন্ট শুধু ফিভার নিয়ে আসছে, তাতে কি হলো ধরা পড়বে, তার মানে কি করতে হবে? তাহলে আমাদের যেটা করতে হবে যে আমরা রুটিন যে ইনভেস্টিগেশন গুলো করি তার বাইরে গিয়ে ইনভেস্টিগেশন গুলো করতে হবে তো। And we also need to look at those pathogens which are not commonly associated with the disease. That is, we have to look for the uncommon pathogens. Okay. ওটা পারলে একটু মনে রাখতে পারো, Petersdorf, one of the first person who had defined FUO, but then I have already told you that definition no longer stands. So that was when a minimum duration of 3 weeks, and today we consider it generally 1 week. আচ্ছা, এটা বললাম যে ক্লাসিক্যাল FUO, nosocomial, neutropenic and HIV based on the patient profile. This is the most important part which I want to stress upon. When we are dealing with FUO, you have to understand there are many non-infectious causes of FUO. It could be of autoimmune causes, it could be of diseases like gout, pseudo gout, metabolic causes. These are also very important. That is, you have to look both from an infective point of view and also from a non-infective point of view. And among the infectious causes, you have to look for certain diseases which are not very common. For example, you have to look for like brucellosis, cat scratch disease, Epstein-Barr virus infections. These are not very common. But when the routine investigation do not give you a clue for diagnosis, you have to look for these diseases. That is the importance of FUO. We can proceed either by organ-wise basis, look for the specific infective causes, and last but not the least, we also have to look at the malignant and the neoplastic causes also. They can also present as a prolonged fever. বুঝা তোমাদের ক্লিনিক্সে ক্লাস হচ্ছে হিস্ট্রি টেকিং some idea আছে so initially what do we take the history of the present illness, then we take the relevant history. Now কতটা extent বা কতটা depth the history নেব, that will depend on the how we proceed. So especially if we are looking at a patient who is suspected of having FUO, you have to take an expanded history. You have to look at the social history, you have to look at the travel history, even you have to look at the sexual history, each and everything very minute. That means you have to re-evaluate the history also. Okay. So now you have understood two important aspects. First is of infective endocarditis and then of fever of unknown origin. Okay. Achha, case definition of Duke's criteria is 2 major or 1 major plus 1 minor and 5 minor criteria. This you have to remember. Another part which I'll discuss very minutely in today's class, that is catheter related bloodstream infections. This will also be covered when we will talk about healthcare associated infections. But just I'm trying to give you some ideas. Okay. Now, when we say catheter related bloodstream infections, I mean intravascular catheter. Don't get confused with the urinary catheter. So the first type of catheter, I think you have seen all in the world very commonly. This is the peripheral venous line. IV cannula, very common. Now, what happens is if this gets infected, it gets infected very commonly, and very commonly it is infected by the skin commensals. And what will happen? There will be inflammation of the veins, and the veins will get blocked. So you have seen your seniors taking out the cannula, putting a new cannula on the other site. That is also called as phlebitis. It may be infective, it may be non-infective. If it is blocked by a thrombus that is formed in the vein, we call it as thrombophlebitis, and sometimes it may be due to infection. Whatever may be the cause, the best way of treating is remove the cannula itself, and if required, put a cannula elsewhere. However, the chances of getting sepsis or bloodstream infection from this is very less, because unlike arteries, the veins will collapse. Hence, the chances of spread will decrease. However, this scenario changes when we try to put the catheter on bigger veins. The first bigger vein is the when we try to put in the superior vena cava, like in this antecubital vein. These are called the midline catheters. The purpose is to put the catheter directly into the superior vena cava. There are many advantages of putting a central line. I am not talking about this. I think you will read elsewhere. We can directly measure the vena cava pressure. We can put a lot of fluids and drugs directly into the vena cava. There are many advantages. Monitoring is also much better. Another type is called as PICC line. This is called as peripherally inserted central line catheter. Now, if you look at the two diagrams over here, what we are doing is we are putting the catheter directly over here. And since the catheter is in superior vena cava, the chances of getting infected is much higher because very common the organism has to traverse a very small distance and it will cause central line infections. To circumvent this, we can also put what is called as peripherally inserted central line catheter. That means the catheter is put in, say, in the over here, and the catheter is stretched directly into the vena. So we can monitor like putting a central line, but the chances of infection are much less. The last type is called as surgically implanted central venous catheter. In some patients, we need to monitor many things routinely. Previously, whatever the two types you have seen, if you go to the ICUs, you will see the patients who are in need of a central line, they will either have a midline central line or a peripheral inserted central line. Some patients, we need to put a permanent central line. So these are put inside the skin. The catheter is underneath the skin. And when we need to access them, we puncture the skin and access the catheter. Now this is surgically planted. These are the common 4 types. Obviously, this is for long-term use and these 2 are for short-term use. Now, you answer. Which type of central line the chances of infection are more? কোনটা বেশি হবে? Midline, PICC line না long time catheter? কেন? আচ্ছা, কোনটা মানে পুট আপ করা মোর ইজি? কোনটা? ইজিয়েস্ট কোনটা প্লেস করা? Midline. Direct vein puncture করে the catheter put করো. This is much easier. এই জন্য দেখবো আইসিইউতে যেগুলো যে পেশেন্টের আমার মনে হয় যে আমার একটা সেন্ট্রাল লাইন দরকার, but for a short period of time, we put the midline. When we suspect this patient will take a lot of time to recover, then we proceed for putting this PICC catheter. আর যাদের লং টার্ম রাখতে হবে তাদের জন্য আমাদের এই লং টার্ম। The first step that happens is called as colonization. Remember, a foreign body, whenever placed anywhere in the body, there will be colonization by microorganisms. কোথা থেকে স্টার্ট হবে colonization? না, মানে আমি যেটা জিজ্ঞেস করছি ভাবো, এই পিকচারটা দেখো, এটা তো ভেন, মাইক্রোঅর্গানিজম অ্যাক্সেস পাচ্ছে, কোথা থেকে পাবে? সোর্স কোথা থেকে? এটাকে বলে দুভাবে সোর্স, একটা হচ্ছে লুমিনাল সোর্স আর একটা হচ্ছে এক্সট্রা লুমিনাল। লুমেন বলতে এইটার লুমেনের কথা বলা হচ্ছে। লুমিনাল সোর্স মানে কি? আমি যে জিনিসটা দিয়ে ফ্লুইডটা দিচ্ছি সেই ফ্লুইডটা যদি কন্টামিনেটেড থাকে তাহলে হতে পারে, অথবা যে হেলথ কেয়ার ওয়ার্কার ওটা খুলছে বার করছে তার হ্যান্ডস আর গ্লাভস যদি কন্টামিনেটেড হয় তখন কি হবে? লুমেন দিয়ে যাবে। আর একটা হচ্ছে এক্সট্রা লুমিনাল। এক্সট্রা লুমিনাল মানে স্কিনের মাইক্রো অর্গানিজমসগুলো ওই লুমেনের বাইরে দিয়ে ঢুকছে। সেটা কখন হবে? সেটা হওয়ার জন্য ফার্স্ট যেটা লাগে দ্যাট ইজ কল্ড অ্যাজ colonization. এই লুমেনের বাইরে they will attach and form a biofilm. By the time the catheter is removed, the patient will have no problem. But if the catheter is still placed in situ, তারপরে কি হবে? Same phlebitis stage, তারপর infection spread করবে. Like this, you can see a peripheral line ছিল, infected হয়ে গেছে, vein গুলো infected and inflamed. I think you can see them. These are called as phlebitis. Then যেটা বললাম, যেখানে আমরা ইনসার্ট করেছি ওই যে স্কিনটা, that area might get infected. That is called as exit site infection. Exit means catheter যেখান থেকে বের হচ্ছে, that is called as exit site. If you look at this picture, ওই সাইটের চারিপাশে there is erythema. Later on, you can also see this is called as tunnel infection. মানে স্কিনে যখন আমরা পেনিট্রেট করি, স্কিন পেনিট্রেট করে তারপরে একটু এগিয়ে গিয়ে তারপর তো ভেন্টের মধ্যে ঢোকানো হচ্ছে, এটাকে বলা হয় টানেল। দুটো কিন্তু আলাদা। মানে সাপোজ দিস ইজ দ্য এন্ট্রি পয়েন্ট, এটাকে এইখানে যদি ইনফরমেশন থাকে, উই কল ইট অ্যাজ এক্সিট সাইট। আর এই যে ভিতরে গ্যাপটা দিয়ে গেল, দিস ইজ এইখানে গিয়ে যদি ইনফেকশনটা স্প্রেড করে যায়, উই কল ইট অ্যাজ টানেল ইনফেকশন। ঘাবড়াবার কিছু না, আমি জাস্ট আইডিয়াটা দিচ্ছি, পরবর্তীকালে আবার ডিসকাস করা হবে। এবার আমরা হসপিটাল সেটিংয়ে বলি, if the infection occurs 48 hours after the placement of the catheter, then only we will consider it as catheter related. This is very important, try to understand. Suppose you have two patients. In both the patients you have put the central line. In the first patient, on the day you have put the central line, blood culture comes positive. And on the second patient, the blood culture comes positive 2 days after placement of the central line. That means if you want to say that the infection is due to a central line related infection, it has to go to all these processes, that is colonization, local infection, and then spreading. It will take time. The minimum time that is required is 48 hours. If 48 hours er age infection ta hoy, that means the infection was present prior to the insertion of catheter. Okay. So we have covered infective endocarditis, we have covered fever of unknown origin, and we have also given you a brief idea about catheter related bloodstream infection. এই তিনটে ক্ষেত্রে whatever happens, end outcomeটা কি হয়? end outcomeটা হচ্ছে bloodstream ব্যাকটেরিয়া আছে যেটা স্প্রেড করছে। Now it can be contained or it may not be contained. If the body is able to contain the infection, what will happen? The bacteria will be removed from the body. But if the patient is unable to contain, what will happen? The bacteria will go on multiplying. And this is what we call it as sepsis. Earlier, there were many terms that were used like septicemia, bacteremia, toxemia. So there was gross confusion. Now please remember, bacteremia means presence of bacteria in the blood. The patient may have sepsis, may not have sepsis. Okay? If there is toxin in the blood, it's toxemia. Sepsis is a clinical condition. Okay? Sepsis is a sepsis এর সঙ্গে blood culture কোনো সম্পর্ক। For example, you are a healthy person, just after early morning you have brushed your teeth, আমি যদি তোমার blood নেই, আসতে পারে। Does that mean you are diseased? No. Sepsis is a disease. So when we say sepsis is a disease, we have to understand this thing. What actually happens? The pathogen, bacteria over here, will cause infection. This will start a chain reaction. The first step of which is inflammation. The inflammation will result in endothelial cell injury in the vessels. This will trigger microcircular dysfunction. Why? And how? Because the vessels are supplying blood and oxygen to all parts of the body. If the vessel endothelium is altered, vascular supply will be direct all over in the body. Furthermore, to try to contain the inflammation, cytokines will be released. These cytokines will further damage. The damage will be more predominant where? At the microcirculation. Not in the large vessels, but predominantly in the small vessels or the microcirculation. Now, if microcirculation is altered, what will happen to the tissues? Tissue perfusion will be deranged. Tissues will undergo hypoxia and will end up in cell death in the tissues. And if in tissues cell death start happening, what will happen to the organs? What are organs? It's an organized group of tissues. টিস্যুতে যদি সেল ডেথ হয় তাহলে অর্গানস কি হবে? Organs will fail. That will organ will not be able to work properly. This is called as multi-organ dysfunction syndrome or MODS. Where? Process is very simple. There is a triggering factor which triggers inflammation, and on inflammation it will result in endothelial injury, recruitment of various inflammatory cells, which will be further amplified by production of cytokines. This will result in microvascular dysfunction at the tissue level, resulting in cell death of the tissues. When cell death of the tissues occur, organ dysfunction is seen. When we recognize the features of organ dysfunction clinically, we call it as sepsis. Let us look at where predominant injury happens. When lymphocytes are affected, immune system is deranged. When epithelial cells are damaged, what are the important epithelial cells? Of the lungs, the intestines, and the kidneys. If it affects the lungs, you will have hypoperfusion. Oxygen exchange, oxygen carbon dioxide exchange will be altered. In intestine, what will happen? Mucosal damage, which will lead to further translocation of other organisms into the blood. In the kidneys, it will lead to acute kidney injury or renal shutdown. And finally, because of the endothelial cells, it can have two outcomes. One is vascular leak and thrombosis. Now, this thrombosis process is intravascular. That means eating up of the coagulation pathway. তার আউটকাম কি হবে? Vessels are already leak আছে, and all the coagulatory proteins are used up. This is called as DIC, disseminated intravascular coagulation. মানে disseminated means throughout the body. Intravascular means the coagulatory proteins are used up within the vessels itself. এরপরে যদি পেশেন্টের কোথাও একটা ব্লিডিং স্টার্ট হয়, সে ব্লিডিংটা বন্ধ হবে, the patient will bleed to death. So organ dysfunction various levels হয়. Vessels এর মধ্যে organ dysfunction will be vascular leak or thrombosis. This thrombosis is not like thrombotic manifestation, but rather intravascular thrombosis, which may result in DIC. In the lungs, it will result in hypoperfusion. In the renal system, it will lead to acute kidney injury, and in the intestine, it will lead to mucosal damage, mucosal ulceration, or translocation of bacteria from mucus into the bloodstream. So this is the pictorial representation of what that is happening. If you can see the picture, the bacteria will trigger the white blood cells, resulting in cytokines, and from there the vessels will leak and then affect all the organs. And this is the process of DIC, in which there is a big process going on. End story is all the clotting factors are used up, and when then there is a bleeding manifestation, bleeding will not stop. Now, for diagnosis of sepsis, the first step you have to understand is called as SIRS. SIRS is also called as systemic inflammatory response syndrome. That means this is the condition in which the patient's body is undergoing a response to inflammation. So what are the response? Because the cytokines, body temperature will be raised. So the patient will have a core body temperature of either the temperature will be raised very high or the temperature will be raised, that is hyperthermia or hypothermia. Hyper means more than equal to 38 degrees centigrade, hypo means less than equal to 36 degrees centigrade. মানে বেশি হতে পারে কম হতে পারে। নেক্সট হার্ট রেট কি হবে? Obviously it will increase whether hypothermia, then respiratory rate. You can have hyperventilation. Hyperventilation কি করে বুঝবে? Respiratory rate বাড়বে। And ব্লাডে কি পিকচার পাবে? Now why this is important? Because if the blood cells are recruited heavily, নাম্বারটা কম পাবে। আবার পেশেন্ট যদি সেই ফেজে আছে যখন সাইটোকাইন প্রচুর রিলিজ হচ্ছে তখন কি হবে? ডাব্লিউবিসি সংখ্যা বেশি পাবে। So you can get a higher WBC count or a low WBC count. Now these are all the manifestation of the inflammatory response. তাহলে কি কি হতে পারে? হাইপো বা হাইপোথার্মিয়া হতে পারে, and হার্ট রেট বাড়বে, রেসপিরেটরি রেট বাড়বে, আর WBCs you can get a high or a low, মানে either 12 or 4000. Now definitions of sepsis, I think কনসেপ্টটা তোমরা বুঝতে পেরেছো, but there is a specific definition. A definition আমার না কারণ না, sepsis 3 definition is sepsis is characterized by a life-threatening organ dysfunction due to dysregulated host response to infection. These are the 3 words you have to remember. It is a organ dysfunction due to dysregulated inflammatory response to infection. এই তিনটে ওয়ার্ড মাথায় রাখতে। আরেকটা টার্মিনোলজি যেটা আছে, সেপসিস তো হলো, তার আউটকাম কি হয়? পেশেন্ট শকে চলে যেতে পারে। You have already heard about shock, hypovolemic shock, this shock, that shock. Sepsis shockটাকে কি বলে? সেপটিক শকটা। Exactly. এই same process is going on. Organ dysfunction হচ্ছে। When this organ dysfunction is to such an extent which may lead to mortality or morbidity or mortality, then we call it as shock. Process টা বোঝা গেছে? First step is SIRS, second step will be sepsis, and third step will be septic shock. How to recognize sepsis? As far as you people are concerned, this is very important. It is called as FUO or quick sepsis organ failure assessment. SOFA stands for sepsis organ failure assessment. নামটা ভালো করে দেখো। It's a criteria to assess organ failure in sepsis. There is an expanded SOFA scoring and there is an abbreviated or quick. ওটাকে বলা হয় quick. এতে আমরা কি দেখি? First is altered mentation. Why altered mentation? Patient disoriented. Why? তোমার রেসপিরেটরি এপিথেলিয়াম যদি গ্যাস এক্সচেঞ্জ ঠিক না হয়, obviously will be disoriented. মনে পড়ছে পার্শিয়াল প্রেসার অফ অক্সিজেন ইন আর্টারি, PaO2, PCO2, PO2 কমে গেলে PCO2 বাড়লে কি হয়? অ্যাসিডোসিস, অ্যালকালোসিস, মনে পড়ছে কিছু কি? বায়োকেমিস্ট্রিতে পড়ানো হয়েছিল। ব্রেনের উপর একটা এফেক্ট পড়ে, দ্যাট ইজ ডিসওরিয়েন্টেশন। এবার এই PaCO2 বা PaO2 যদি মেজার করতে আমাকে তো আর্টারি ব্লাড গ্যাস অ্যানালিসিস করতে হয়, স্লাইটলি কমপ্লেক্স প্রসেস। কারণ আমি যখন ওয়ার্ডে একটা পেশেন্টের কুইক অ্যাসেসমেন্ট করবো, আমি তো ওটা করতে পারবো না। তাহলে ফার্স্ট অ্যাসেসমেন্ট কি? লুক অ্যাট দ্য ওরিয়েন্টেশন, মেন্টেশন কি, ডিসওরিয়েন্টেড কিনা। নেক্সট ইজ রেসপিরেটরি রেট, যদি গ্যাস এক্সচেঞ্জ যদি অল্টার্ড হয়, পেশেন্টের বডি কি করবে? কম্পেনসেট করার জন্য রেসপিরেটরি রেটটা বাড়াবে। সো দেয়ার উইল ইনক্রিজ অফ রেসপিরেটরি রেট, অ্যান্ড ফাইনালি ইউ উইল হ্যাভ systolic blood pressure of less than 100 millimeter of mercury. that is SBP less than 100. That means in spite of increased respiratory rate, in spite of increased heart rate, patient cannot maintain blood pressure. যখন ব্লাড প্রেশার মেনটেন করতে পারছে না তখন আমি বলছি দ্য পেশেন্ট মাইট বি ইন শক। সো দিস ইজ দ্য কুইক সোফা স্ক্রিন। এইটা মেজার করার জন্য ইউ ডোন্ট নিড টু হ্যাভ এনি ইন্টারভেনশনাল স্টাডিজ। রেসপিরেটরি রেট মাপো, ব্লাড প্রেশার মাপো, ওরিয়েন্টেশন মাপো, তিনটে যদি অল্টার থাকে most probably the patient is in shock. More expanded form is the SOFA scoring, in which we look at the partial pressure of oxygen, platelet, bilirubin, Glasgow Coma scale, creatinine. That means patient normal examination finding along with laboratory findings. This comprises of the SOFA scoring. ঠিক আছে, এছাড়াও আরো অনেক স্কোরিং আছে, লাইক ক্রিটিক্যাল কেয়ার অ্যাপাচে স্কোরিং আছে, ওগুলো এখন তোমাদের লাগবে না। What you need to understand is what is sepsis, what is SARS, what is the definition of sepsis, what is septic shock, and how to recognize them. To recognize septic shock, you need to know the Q SOFA score or quick sepsis organ failure assessment. এবার যদি আমাকে এস্টাবলিশ করতে হবে যে পেশেন্ট শকে গেছে, তাহলে আমাকে কিভাবে এস্টাবলিশ করতে হবে? শকটা কখন বলছি? অর্গান ডিসফাংশন তো হচ্ছে। If I don't intervene, what will happen? It will result in morbidity and mortality. That means একটা পয়েন্টের উপর টিপ ওভার করছে, সেটাকে আমরা বলছি শক। What is that point? That point is need of vasopressure to maintain the mean arterial blood pressure more than 65 mm. That means vasopressure নাম শুনেছো তো, ফার্মাকোলজিতে পড়ানো হয়েছে তো, নরঅ্যাড্রিনালিন নাম শুনেছো তো, এগুলো কি করে? হার্ট ব্লাড প্রেশারটাকে বাড়ায়। এটা কি বলছে? নিড অফ ভ্যাসোপ্রেশার টু মেনটেন দ্য মিন আর্টারি, মানে যেটা নর্মালি থাকার কথা সেটা মেনটেন করতে পারছে না, আমাকে বাইরে থেকে ভ্যাসোপ্রেশার দিতে হচ্ছে। দ্যাট মিনস আমি যদি ভ্যাসোপ্রেশারটা তুলে নিই তাহলে কি হবে? পেশেন্ট কোলাপস করে যাবে। দ্যাট মিনস দ্য পেশেন্ট ইজ ইন শক। দ্যাট ইজ দ্য ফার্স্ট পয়েন্ট। সেকেন্ড পয়েন্ট ইজ এলিভেটেড সিরাম ল্যাকটেট greater than 2 despite adequate fluid resuscitation. বডিতে ল্যাকটেটটা কখন বাড়ে? দুটো সিনারিওতে, যখন হচ্ছে অর্গান ডিসফাংশন হয় আর না হলে বডি ডিহাইড্রেটেড হয়। বডি ডিহাইড্রেশন খুব কম, যারা অ্যাথলেটিক্স করে, জিম করে, মানে সিভিয়ার ওয়ার্কআউট করে, বডি ডিহাইড্রেট হয়ে যায়, ল্যাকটেট লেভেলস বেড়ে যায়। এখানে কিন্তু ডিহাইড্রেশন না, মানে ইউ হ্যাভ গিভেন অ্যাডিকুয়েট ফ্লুইড, নট বিকজ অফ ডিহাইড্রেশন। তাহলে কেন ল্যাকটেটটা বাড়ছে? বিকজ অফ টিস্যু হাইপোপারফিউশন। বোঝা গেছে ল্যাকটেট কখন বাড়ে? আমি যদি প্রচুর দৌড়ঝাঁপ করি কি হবে? টিস্যুতে মেটাবলিজম বাড়ছে, সেই জন্য ল্যাকটেট বাড়ছে। আর একটা কোন সিনারিওতে ল্যাকটেট বাড়বে? যখন ইন অ্যাবসেন্স অফ অক্সিজেন মেটাবলিজম হচ্ছে, যেটা শকে হয়। মেটাবলিজমটা বাড়ছে না কিন্তু অক্সিজেনটা কমে যাচ্ছে, তাহলে টিস্যু হাইপোপারফিউশনের জন্য ল্যাকটেটটা বাড়ে। তো আমি ক্লিনিক্যালি কি দিচ্ছি? পেশেন্টটাকে আমি অ্যাডিকুয়েট ফ্লুইড দিয়েছি, তারপরেও দেখছি ল্যাকটেট বেশি হচ্ছে। দিস আর দ্য টু সিনারি। এই দুটো সিনারি হলে তার মানে দ্য পেশেন্ট ইজ ইন সেপটিক শক। দিস আর দ্য লিস্ট, আই থিঙ্ক বইয়ে পেয়ে যাবে, যত বেশি পড়বে বুঝতে পারবে। দিস আর দ্য কমন অর্গানিজমস হুইচ কজ সেপটিক শক অর সেপসিস। বোথ দেখো, গ্রাম পজিটিভ, গ্রাম নেগেটিভ, ইভেন অ্যানোরোবিক viruses and even fungi, they all can cause sepsis. So don't think শুধু ব্যাকটেরিয়া সেপসিস, ফাঙ্গাল সেপসিসও হয়, ভাইরাল সেপসিসও হয়। ভাইরাল সেপসিস এর very common example is dengue and even কোভিডও পাওয়া গেছে। And sometimes some non-infective cause can also present like this, like trauma, বার্ন, মেজর সার্জারি, ওখানেও কিন্তু ট্রিগারিং ফ্যাক্টর ইজ ইনক্রিজ সাইটোকাইন। প্রত্যেকটা যদি দেখো ইনক্রিজ সাইটোকাইন। ওকে, বাকি অ্যাপ্রোচ টু সেপসিস I think তোমাদের এখন লাগবে না। Well, that would be it. So পুরোটাকে যদি recapitulate করা হয়, if we look at all the infective conditions of cardiovascular system, we have infections of the vessels and we have infection of the sequelae. In case of infection of the vessels, we start with artery, যেগুলো peripheral arteritis পাওয়া যায়, more commonly of autoimmune diseases, veins, thrombophlebitis, very commonly seen. আর একটা যেটা important হচ্ছে in case of veins, that is infection of the central venous line or catheter related bloodstream infections, which is seen in the healthcare settings. Next would be endocarditis and myocarditis. Very commonly endocarditis is seen. Endocarditis may be acute endocarditis, may be subacute endocarditis. Based on acute and subacute, some organisms will cause acute, some will cause subacute. Again, native valve, prosthetic valve organism spectrum different. Culture positive, culture negative, spectrum different. These are the infective processes. We have to consider the infective process, especially with the setting of what is called as fever of unknown origin. What is fever of unknown origin? It's a clinical condition when the patient is having fever, and even after about 1 week of directed investigation, there is no possible diagnosis. সেটাকে আমরা বলছি fever of unknown origin. এটাকে আবার ক্লাসিফাই করা হয় 4টে টাইপে, either classical FUO or nosocomial FUO or HIV related FUO based on the patient profile. Importance of FUO is we need to look deep or delve further into the relevant history. সেটা travel history হতে পারে, social history হতে পারে, sexual history হতে পারে, and we also have to take into consideration of the less commonly causing diseases or diseases which are not commonly associated and non-infective. And final part is we have to understand what is sepsis. Sepsis means an inflammatory condition. Initial part is called as SIRS or systemic inflammatory response syndrome. And when this process goes on and is associated with vascular endothelial injury, vascular leakage, and tissue hypoperfusion, we get what is called as sepsis, which may manifest with what is called as MODS or multi-organ dysfunction syndrome. And when this multi-organ dysfunction syndrome can lead to morbidity or mortality, we call it as septic shock. Diagnosis of sepsis can be done by a scoring criteria called as SOFA or systemic organ failure assessment. There is a quick SOFA scoring for bedside assessment, and for diagnosis of septic shock, you have to assess mean arterial blood pressure is not being able to maintain the patient in spite of vasopressure, and increase of serum lactate in spite of adequate resuscitation. এই দুটো কন্ডিশন থাকলে that means the patient is in septic shock. বোঝা গেছে? এবার জাস্ট কমন সেন্সে আনসার দাও, যদি পেশেন্ট সেপসিস বা সেপটিক শকে থাকে কি করবে? জাস্ট কমন সেন্সে আনসার, কি করবে? হ্যাঁ, আর মানে ইনভেস্টিগেশন করবে, ব্লাড কালচার করবে, আর সবার আগে পেশেন্টকে তোমাকে বাঁচাতে দেবে, ইনভেস্টিগেশন তো হবে। ভেরি গুড, অ্যান্টিবায়োটিক দেবে। আর সবার আগে পেশেন্টকে রিসাসিটেট করতে হবে, ইনভেস্টিগেশন পরে। ইউ ক্যান ইভেন ডেফার অ্যান্টিবায়োটিক্স, যেটা আগে পেশেন্টকে রিসাসিটেট করতে হবে। কেন? পেশেন্টের হাইপোপারফিউশনটাকে ঠিক করতে হবে। হাইপোপারফিউশন কীভাবে ঠিক করতে হবে? অক্সিজেন বাড়াতে হবে। যদি রেসপিরেটরি রেট বাড়তেই থাকে তোমাকে ইন্টুবেট করতে হবে, মানে মেকানিক্যাল ভেন্টিলেশন দিতে হবে। পেশেন্টের যদি রিনাল ফেলিওরে চলে যায় তাহলে তোমাকে রিনাল রিপ্লেসমেন্ট থেরাপি দিতে হবে। পেশেন্টের যদি ব্লাড মানে হাইপোভলিমিয়া হয় তোমাকে ফ্লুইড রিপ্লেসমেন্ট করতে হবে। যদি নাম্বার অফ ক্যারিং আরবিসিস কমে যায়, ইউ ক্যান ইভেন হ্যাভ টু গিভ ব্লাড ট্রান্সফিউশন, ঠিক আছে। অ্যান্ড অ্যান্টিবায়োটিক্স অ্যান্ড অ্যান্টিফাঙ্গাল অ্যান্ড অ্যান্টিভাইরাল, যেগুলো পসিবল। কেন? টিল তোমার ল্যাবরেটরি থেকে ফাইনাল কনফার্মেশন is not there, you don't know what is the causative agent. Okay, and finally you have to look for the focus. Most of the time যদি sepsis থাকে, that means there is a infective focus somewhere in the body. Lungs এ থাকতে পারে, renal system এ থাকতে পারে, musculoskeletal system এ থাকতে পারে, even meningitis may present as sepsis. So you have to look for focus of infection. That means তোমার ডায়াগনস্টিক্সটা হবে ডাইরেক্ট, ঠিক আছে। সো দিস ইজ দ্য জেনারেলাইজড আইডিয়া যেটা তোমাদের মাথায় রাখবে। নেক্সট টাইম যখন ওয়ার্ডে বা আইসিইউতে যাবে, ট্রাই টু লুক ফর দিস থিংস। ওকে।